I'm Dr. Gurpreet Wander from Ludhiana. I must thank Wincars and especially Dr. Shiba Tucker for giving me this opportunity to speak at the heart failure conclave, which we are having uh, along with the Cardiological Society of India. The topic that has been assigned to me is to speak on the heart failure with preserved ejection fraction. As you all know, this is a different subset of patients. 20 years back, we did not recognize and realize the value of this particular condition. And most of the work and studies were done on heart failure with reduced ejection fraction. However, we have realized almost 40 to 50% of patients world over with heart failure belong to the heart failure with preserved ejection fraction. This particular condition, patients behave differently. Their prognosis is a little bit better than reduced ejection fraction. These patients often get hospitalized, and it is a little bit of a different kind of disease than patients with heart failure reduced ejection fraction, for the simple major reason that most of the drugs that we use in patients with heart failure reduced ejection fraction, they do not actually impart the similar benefit in terms of mortality reduction in patients of heart failure reduced ejection fraction. So I'll just touch upon this particular issue uh, in the next about 10 odd minutes that have been assigned to me. This is something that we've already discussed, actually, that heart failure preserved ejection fraction has more than 50% ejection fraction. And essentially, the diagnosis is based on elevated natriuretic peptides. And of course, along with that, there should be echocardiographic evidence of diastolic dysfunction, and either there should be left atrial enlargement, left ventricular hypertrophy. Mostly patients of heart failure mid-range ejection fraction, which is between 40 to 49%, they behave similar to heart failure preserved ejection fraction. And so these patients are clubbed often together. But we do realize that these people almost actually, in terms of response to drugs, they respond in the direction of heart failure reduced ejection fraction, as you will gather in the next 8 or 10 minutes. So they essentially need to be actually looked upon as mid-range ejection fraction patients only. So this is a pictorial depiction of systolic heart failure and diastolic heart failure, what we earlier used to say. And now we have the heart failure with preserved and reduced ejection fraction. As I just said, it was only in 1984 that these two landmark papers in the American Journal of Cardiology actually emphasized that we can have patients with clinical features of congestive heart failure with normal systolic functions. And also it was realized that these people with intact systolic functions, they behave differently in terms of response to therapeutic strategies. And thus this initiated the era of our realization of heart failure preserved ejection fraction. Over a period of time, we have realized these people are elderly, they are more often obese, they need a sedentary life. Hypertension is a very important risk factor for this. And more of these patients are diabetics, obstructive sleep apnea, chronic kidney disease. These are more common in heart failure preserved ejection fraction than heart failure with reduced ejection fraction. And so this particular entity is to be taken actually as a separate entity, and we should not mix it up with heart failure reduced ejection. A lot of these patients actually we have to exclude anemia, thyroid disorder, chronic obstructive pulmonary disease, constricted pericarditis, and also the other high output states, because they can change the way we look at these patients. And these particular factors can alter the diagnosis when we find ejection fraction normal, clinical features of heart failure, and even some infiltrative disorders like amyloid heart disease, other sarcoidosis, and hypertrophic cardiomyopathy also clinically, when they go into heart failure, they could actually behave akin to these. So typically you need clinical symptoms of heart failure, that is dyspnea and fatigue, ejection fraction which is preserved, and elevated filling pressures and raised BNP levels. So as I said, the comorbidities are important, and most people believe there is a systemic inflammation and multi-organ involvement in this particular condition, which results in endothelial cardiomyocyte signaling, more inflammation, more fibrosis, and that distinguishes pulmonary artery hypertension, and that distinguishes this diastolic kind of heart failure from systolic heart failure that we have in reduced ejection fraction. So if you look at the two extreme phenotypes, on the one hand, we have people with renal, more of comorbidities. On the other hand, we have people with infiltrative disorders, but most patients would belong somewhere in between this, and the phenotype will be actually of a mixed variety. In the Asian heart failure registry, which we were a part of, actually we looked at patients with heart failure preserved ejection fraction. The fraction of patients were less, about 25% of the patients were heart failure with preserved ejection fraction. But some very revealing data, South Asians had actually the least 1-year mortality as compared to Northeast Asia, that is Japan, South Korea, China, and Southeast Asia, that is Indonesia, Malaysia, Singapore, Philippines. They had the highest overall, and so also heart failure preserved ejection fraction. So there are significant regional differences within Asia in terms of mortality. The treatment actually essentially involved, we need to consider alternative diagnosis and rule them out. Diuretics have been the mainstay to reduce the congestive state. Good blood pressure control is very, very important. Treatment of comorbidities, rate versus rhythm, and of course, treatment of ischemia. Till now, these are the various factors actually which we were emphasizing on in terms of management of heart failure preserved ejection fraction patients. We had a lot of hope on the TopCat trial, which was published in 2014 in the New England Journal of Medicine. Around 3,500 patients were followed up for 3.3 years. Only hospitalization for heart failure were reduced. Total deaths, hospitalization for any reason were not reduced. And so this was, in that sense, a negative trial. Although people believe that there is more fibrosis, so there was a lot of hope on this particular trial. If you actually look at the way the charms preserved, the eye preserved, so in the last about 10, 12 years, there have been more interest. And now, of course, this is something which we are going to discuss in the last couple of minutes actually of my talk, the Emperor Preserve trial and the upcoming Deliver trial. If you actually look at the initial trials, whether it was the charms preserved, the eye preserved with irbesartan, candesartan, or the PEP-CHF trial, which was done with perindopril and the TopCat I just mentioned, they were all negative trials. And so we realized that we cannot interpolate data from heart failure with reduced ejection fraction in terms of using these agents in patients with heart failure preserved ejection fraction. And so we realized that essentially, just as I showed you in the previous slide, we only have good use of blood pressure control and some diuretic usage. This is a meta-analysis which showed that the RAS blockers, the benefit were almost negligible in patients with heart failure preserved ejection fraction. And so the 2017 Latin ACC-AHA guidelines have suggested that class 1 treatment is systolic and blood pressure control, diuretics, and at best, actually, coronary revascularization is very important if you find coronary artery disease as a cause, management of atrial fibrillation. And these agents are actually, even the European latest 2021 guidelines suggest that whether it is ACE inhibitors, ARBs, beta blockers, MRAs, they all actually are 2B indications for use in heart failure with mildly reduced ejection fraction actually. You will realize that as ejection fraction goes up, these drugs also do not give any benefit. The Paragon HF trial, which was published in 2019, was a trial with great potential, and we were already looking at this particular trial after the Paradigm trial in heart failure with reduced ejection fraction. What we found was actually the primary endpoint was not reached. There was no statistical significance, although we did realize that very important finding, women derived greater benefit, and people with lower ejection fraction, they derived greater benefit than people with more with higher ejection fractions of more than 57%. How are women different? Maybe they have smaller hearts, maybe the adipose tissue distribution is different in them, and that results in a higher state of inflammation, greater neurohormonal activation, and adverse response to exercise, and that is what makes it different. It's very interesting. And especially for the WinCar audience, we need to actually look at how we can best see women acting differently. In terms of ejection fraction, we now realize that people with lower ejection fraction, that is mid-range, they derive greater benefit. Although FDA has approved sacubitril valsartan in selective patients with mid-range ejection fraction, but as the ejection fraction goes up, the benefits are less in these people. So heart failure preserved ejection fraction, we were actually without any benefit imparting drug. But in the last year, we had the SGLT2 inhibitor trial. SGLT2 inhibitors act primarily on the proximal tubular cell, where they block the SGLT receptor, and thus the sodium potassium excretion is reduced. There is increased uric acid excretion. There is greater glucose-urea natriuresis, and this results in lowering of blood glucose level, lowering of body weight, blood pressure, uric acid, and glomerular hyperfiltration. In fact, most of the CV outcome trials, whether it was EMPA-REG, DECLARE, CANVAS, VERTIS, with empagliflozin, dapagliflozin, canagliflozin, or artegliflozin, they were all positive, and we did have initial indication that they reduce CV events. In heart failure, the DAPA, HF, and the Emperor reduced showed that they are beneficial in heart failure. And today, for this reason, we all started using dapagliflozin and empagliflozin in our patients of heart failure with reduced ejection fraction, whether they had diabetes or not, because the extent of benefit was similar. So this is the trial which is most interesting. It has been published in October, just a short while, and it's the most talked of trial today, the SGLT2 inhibitor in heart failure with preserved ejection fraction with empagliflozin, a phase 3 trial, ejection fraction of more than 40%. It's the first trial in which 10 milligram empagliflozin used once a day. These are the inclusion and the exclusion criteria. And what we found was there was significant reduction in the primary endpoint. There was greater reduction in heart failure hospitalization than in CV deaths. The benefits were more, whether they were diabetics or non-diabetics, benefits were similar. They were a little bit more in women and a little bit more in people with lower ejection fractions. And so I'd like to conclude here by making a couple of statements. Heart failure preserved ejection fraction is not uncommon. We should diagnose it more often, and the NT-proBNP and the BNP levels actually help us in the presence of structural heart disease. It has definite diagnostic criteria. Various scoring systems have been produced, and most drugs that are effective in heart failure reduced ejection fraction have not been shown to be beneficial. There was some benefit with sacubitril valsartan, but it is actually the SGLT2 inhibitor which is actually made all the difference. And today our approach in terms of managing patients of heart failure with preserved ejection fraction is we at least have SGLT2 inhibitors which are beneficial. People with heart failure, mid-range ejection fraction, even sacubitril valsartan imparts benefit, although more in women than in men. Thank you very much.